Today's episode of the World's Ok-Est Physical Therapist podcast is going to focus on Ehlers Danlos syndrome. But first, and always, this show does not replace medical advice. It is educational, and if you are suffering from any sort of condition that is limiting your range of motion, your strength, your ability to do the activities and hobbies that you love, I cannot strongly recommend enough you go and talk to a medical professional about it. If this is a condition that you think that you have, again, this is not medical advice, and this does not replace medical advice, and it does not replace medical evaluation. You need to go and talk to a healthcare professional. Now that that's out of the way, let's talk about what Ehlers Danlos syndrome is. It is effectively a genetic mutation of the protein collagen, and collagen is one of the foundational building blocks of the body. It is the rebar of your body, if you will. We all know that there's concrete. You pour that concrete into a mold, and then you add metal rebar, in order to provide extra structure and stability. Now, what would happen if you had your body full of concrete, but the rebar was so bendy that it didn't actually provide structure? Well, what would end up happening is you'd have a very bendy, a very malleable structure that shifts over time and cannot resist forces or provide stability. And that's exactly what happens with Ehlers Danlos syndrome. Effectively, what happens over time is the tendons, the ligaments, the skin, the joint capsules all become overloaded to the point where they can no longer provide stability. And what tries to make up the stability in a lot of these cases, which we're going to be talking about later, are the muscles and the tendons. The muscles and the tendons try to shore up the gap for stability that the ligaments and the joint capsules can no longer fulfill as the joint ages. Now, there is a sister condition to this known as hypermobility spectrum disorder. That is for people that have a similar presentation, meaning they are also hypermobile, but they do not have the genetic markers for the collagen mutation. So it is a similar condition, but the cause is different. And from a physical therapy standpoint, again, this is educational, you really just take a look at how a person is moving in terms of their range of motion and their strength, and that's what you treat. If they are weak, you strengthen them. If they have range of motion issues, you either improve their range of motion if they're lacking range of motion, or you help them stabilize themselves within their range of motion. Or if they're presenting with painful range of motion, you try to improve the range of motion to not be painful. And for EDS patients later in life, that is definitely something that shows up, is all joint mobility can become painful because of some factors we're about to talk about here. Now, for a lot of people that have EDS, they start out young, they're hypermobile, they think they have a flexibility advantage, they show off to their friends that they can bend in ways that they can't, but later on in life, like I said, the joint stability issue becomes paramount, and what was once a cool gift or a party trick, for example, ends up becoming something that is painful and hindering them from doing what they want to do. Now, let's talk about 3 systems that you have in order to stabilize your joints. The first one is called the active system. That is your muscles and your tendons. These are the things that provide stability across a joint when you're actively trying to move, or when you're actively trying to brace, or what we call in physical therapy guarding. That's where you tighten up your muscles as much as you can to try and prevent a joint from moving. The second is the passive system. This would be your ligaments and your capsule. Ligaments connect bone to bone, tendons connect muscle to bone. So when I'm talking about ligaments, I'm talking about connective tissue that is not designed to stretch or to contract. It's just designed to provide constant stability. The other part of this is your joint capsule. Your joint capsule also helps connect bone to bone while still allowing for range of motion. This is particularly important in, say, for example, your shoulder and your hip. And then finally, you have the neural system. That is where the nerves come into the joint that help you know where your body is in time and space. This is called proprioception by physical therapists. And basically, it allows your body, again, to know where it is in time and space so it can better map movement. In EDS, the passive system becomes unreliable. Things get stretched out and stability decreases. So the neurological system and the muscles and tendons try to step up to make up for the deficiency of the passive system. What ends up happening, though, in the vast majority of EDS patients, is the neurological system fails next. Not only does movement um, become harder for the brain to track because it has extra range of motion, so the nerves, as the tissues get stretched out, they have a harder time sensing where the body is in time and space. They also start sending pain signals because one of the brain's adaptations to EDS is, well, all this extra range of motion is leading to injuries. It's leading to shoulder dislocations. It's leading to rolling ankles. It's leading to all these issues. So therefore, this extra range of motion should be perceived as pain. That's the brain's adaptation. It starts perceiving end range of motion as painful. And that leaves just the muscles and the tendons left to try and provide stability. Like I kind of touched on, a lot of people that have hypermobility issues look clumsy or careless, but the problem is their nerves don't know where they are in time and space, and the brain is having a hard time perceiving where they are in time and space. And they usually have, like I said, a history of issues like rolling their ankles and such. And that kind of feeds into their movement patterns where they're going to avoid situations where they can have that. The reason why the muscles get overworked is because they are doing a job that they were never meant to do. They're trying to provide stability by pretending to be ligaments. And remember, ligaments attach bone to bone, while muscles and connect to tendons, and tendons connect to bone to provide movement. So the muscles end up getting tight, tired, and cranky because they're trying to provide passive stability that they were never meant to. So what ends up happening is a person with EDS over time ends up developing a lot of tight muscles. Now, this is a by and large rule. This is not true for every person. What ends up happening is a lot of major muscle groups become tight because the brain and the muscles and the body are trying to find ways to create stability. And one of the ways that you create stability around a weak joint or a loose joint is you lock all of the muscles down. This is called protective muscle guarding in the physical therapy business. And what it does is this limits the range of motion that they have. Now, in an EDS patient, limited range of motion can look like normal range of motion for a human being. So when a physical therapist isn't careful, if they're going in and evaluating somebody, they just perceive it as normal range of motion on one side and extra range of motion on the other side. But the truth is, for that human being, they might be limited in their range of motion. Now, again, along that lines, what ends up happening, the mistake that ends up usually being made is that when a person that has EDS senses muscle tightness, they want to stretch. They've lived their entire lives being extra bendy and extra flexible and having extra range of motion. Now they've found a joint that doesn't move the way the other one does. Ergo ipso, it must be tight, it should be stretched because tight muscles must be stretched. The problem is, once you go in and stretch those muscles, you took away the stability that the joint was relying on. And that feeds into the pain and the movement disorder. So, instead of doing long hold passive stretches, which we're all very used to, active mobility and end range strengthening is much more indicated. So, that is something that a physical therapist, such as myself, would definitely be working on with a patient that has EDS. Is, hey, let's move through the range of motion that you do have that is pain-free, and let's load through there in order to improve your range of motion and also strengthen you throughout your entire range of motion. The other big cue is, even in the joints that are not presenting an issue yet, a lot of the times EDS patients are doing what is called hanging on the ligaments. That means they're not actively using muscles. They're relying on the ligaments and they're relying on the joint capsules to give them stability. And the best example of this that I know, that I actually do myself, is when a person hyperextends their knees and then rests in hyperextension in order to get stability, instead of keeping their knees slightly bent and using their quads, hamstrings, etc. to give them stability. And that's something that a lot of EDS patients require constant cueing because they do it in their rest state. Just standing there or just going for some sort of movement like a hinge or a squat, a lot of times they'll find ways to rest on their ligaments while locking their knees out, locking their elbows out, or W sitting, for example. So one of the cues that I give myself is always keeping my knees bent and always feeling my quads burn just a little bit. This means that things like yoga and stretching have to be very focused when it comes to an EDS patient because, again, they already have such good range of motion and they already have a little bit of maybe muscular tightness that's given them improved stability. It's knowing the intent and the purpose behind yoga and stretching in order to help them stay healthy instead of potentially pushing further than they should and causing increased stability around a joint. Strength training is going to be, in my opinion, the single most important thing that a person with EDS needs. Because a lot of times they have such good range of motion that what they're really lacking is end-range strength and also just strength to stabilize the joint in general. But the evidence is clear on this. Exercise therapy, that is progressive strengthening and neuromuscular control, is the first line management for any hypermobility related pain and instability. That means there's no brace, there's no medication or passive modality that substitutes for the muscle. The muscles become the adjustable stabilizers of the movement system. You can't tighten ligament with training, but you can build an active system with the brain, the muscles, and the tendons in order to help compensate for the lack of passive stability. Stronger muscles means better motor control, which means a joint that behaves as a stable joint instead of one that is unstable. So, one of the things that I do in the clinic all the time is an isometric. That is an exercise where the muscle doesn't change length; it stays the same length. So, for example, if I was going to do a bicep curl without a dumbbell, and I placed one hand on top of the other to resist myself doing a bicep curl, and then I contracted my bicep trying to push through my hand, that's an isometric. What this does is it helps build strength while calming the nervous system down. The nervous system contracts and it notices that it's not causing pain because it's not causing motion. And this allows the body's nervous system in order to relax, calm down, and provide better feedback to the brain of, hey, I can move or I can tense up and not cause pain. Eventually, this allows for better and improved pain-free active range of motion, which in turn leads to better range of motion for the patient when they're doing any sort of mobility thing. Other things that this looks like, I know I said like resisting yourself in a bicep curl. This could also look like, for me, for example, wall sits, doing a split squat hold, doing bandage shoulder work where I'm holding it for 10 seconds 10 times. All of this is what I use for myself, and whenever I have a flare-up, I use it for myself as well if I strain in my shoulder, my hip, or whatever. One of the other important principles is control before loading, and then loading gently before intensity. So control before load, meaning can the person move through the range of motion with good control, knowing where their body is in time and space before I load them. Then I add weight. Then I focus on if speed is a part of the component. The last thing, as I do with any patient, that I would focus on with somebody that had EDS is plyometrics. Only after they have the pain-free range of motion, they have control through the range of motion, and they've been able to be loaded through range of motion. And kind of along with that, I've found personally that closed kinetic chain interventions, that means having the limb that you're working being in contact with the ground the entire time, is easier and more beneficial to do than open chain. So feet pressing against the leg press machine, that to me is fine. Squats, lunges, calf raises, all those tend to work. And if I can do shoulder stability exercises, like maybe bird dogs or things like that, all of that allows me to focus on closed chain interventions first because they get such good feedback. They get joint compression. They get better proprioceptive feedback than they would an open chain exercise where they're just doing a dumbbell fly and they can't really tell where their arm is in range. Kind of along with those lines, I don't really try to train anybody into end range as fast as possible. I kind of let that naturally happen. I focus on trying to get them to control through the range of motion that I know they're stable in and they're pain-free in, and I build out from there. Proprioceptive work is another thing. I provide so many cues to a patient every probably minute of making sure they know where they are in time and space that this this almost slipped my mind because I'm always saying, hey, where do you feel like you are? Pay attention to where. Do you see where you are? Do you feel the muscle contracting? Do you feel the tightness? Are you feeling where are you feeling tightness? What muscle do you feel contracting? I'm trying to get the patients to talk to me as much as possible to tell me all the biofeedback that they're getting so I can better understand how their joint is moving and what they're perceiving. And then recovery. Recovery is critically important. Sleep, protein, deload weeks, and then having an idea for what to do when they flare up, which is effectively what I tell most of my patients. Drop down to isometrics and do isometric holds and to build yourself back up just like we did in clinic. That is some of the biggest tips and tricks I've learned, and it seems to me, at least from the literature that I've been reading, to be backed by what I'm doing. For teens specifically that I've seen in the clinic, their laxity is pretty significant. And in late teens is when I think I really start to see it becoming painful, but early teens not so much. And it's kind of tied to their growth spurts because when the bones lengthen fast, they start having the motor control issues, and that starts really feeding into the proprioceptive issues. Again, from my experience. So it's kind of like the bigger they get, the brain has a harder time knowing where it is in time and space, and it just kind of makes sense. A lot of times, too, the sports selection that EDS patients have, they usually select to go into sports that reward them for that, like dance, specifically ballet, gymnastics, swimming, cheer. And this all presents specific and unique challenges that they need. And the fix, again, in my opinion, isn't telling them to quit. It's trying to pair the sport with dedicated strengthening that most teen programs skip. And the reason why is they're a special patient. A person that has EDS is going to have special considerations and special limitations and special needs that your average teen isn't. And they really do, I know it sounds kind of tropey, they really do self-select for like the sort of worst thing that they could. They really do go for like gymnastics or ballet where they're going to be punishing their joints because it's their natural gifting. And then getting in there and strengthening them earlier and helping them get in touch with their body with the proprioception really does seem to make a much more significant difference than most people think. One of the things that goes along with that is educating parents too, of saying, hey, your child has this ability to move this way, but we have to be really diligent on their home exercises. We have to be really diligent on how they're loading and how they're being strengthened in order to help them keep doing what they love longer without the risk of injury. And what feeds into that too is a lot of times you have both ends of the spectrums. You have sometimes a patient or a parent who comes in that any sort of pain ever must be immediately evaluated by a medical professional, which is, the safer option, or the one where it's, nah, you're fine, all you're having is growing pains. And EDS is more prevalent in girls, and girls that are doing ballet and not swim, but like cheer, maybe swimming as well, and gymnastics. They're all told, hey, pain is part of the game, and they don't really learn to differentiate between growing pains, pains from the sport, and then perhaps pains in the joint from having EDS, because they don't know any different because they're a teenager and they've only been living with this as far as they can remember for 10 years. And so that's worth discussing with the patient and their parent. And then, again, the final part here, explaining to a teen is, you like being able to move now like you are, let's make sure we help you move as long as possible the way that you can with better strength, better range of motion to help you stay doing what you love longer and not end up as a 30-year-old with a whole host of stability issues and strength issues because you didn't put the work in now. And that's how I like to frame it is, hey, you like moving how you're moving now? Yes, of course. Well, I want to help you move like the way you're moving now for as long as humanly possible. So will you work with me to make sure we can improve your strength, maintain good, safe range of motion, and help you being a super effective cheerleader, for example? And almost any kid's going to say, be better at this longer forever? Yes, of course. And then a lot of times I'll make the point of you don't want to end up like me, a 30-something-year-old person who also has a hypermobility issue, and he has to be doing a lot more work now to make up for it than he would have if he got it when he was younger. And then finally, for adults, um, a lot of adults get diagnosed really late in life, and they've been told for years that they're just injury prone, or they're hypermobile, or they're double jointed. And so finally, when they hear that their condition has a name, they kind of latch on with it, and they don't understand a lot of times that that diagnosis comes with a playbook to get better. Um, Worse, when they find out that there is a playbook to help them get better, they find out that it's like what they would consider embarrassingly light and boring. And it's all about getting in touch with your body. And it's almost meditative. And that then they also find out that progress is not linear with this, it's undulating. And then they really, really, really get frustrated. So a lot of education up front is what I provide, where I'm like, hey, you are not going to be linear. There's going to be issues, there's going to be things that happen, but the general trajectory should be upward, and we should be able to improve your strength and your pain-free range of motion, and most importantly, your stability. But also, we're going to have to retrain all of your movements to make sure that you're using the right muscles for stability instead of hanging on those ligaments. And this ends up turning into a lot of like lifting mechanics and specifically tailoring things to different people with different issues. And then, of course, running specifics like, okay, what is your cadence? Making sure the ankles specifically are strong to prevent rolling, and then as well as the hip and the knees, because you don't want the hip and the ankles to be weak and that be leading to more knee issues, and you don't want a weak ankle that you roll, and you definitely don't want a weak hip that has downstream effects and all sorts of things. Some of the other things that are really important to notice too, because like I said, EDS impacts women more than men, is knowing how the monthly cycle impacts that, because they will have a change in laxity and a change in symptoms. And this is especially true when you get into pregnancy as well. So training is highly important for them to have stability. Okay, that is something that every PT should be, if they have an EDS patient, they should be diving into, to know in case that patient becomes pregnant, how am I going to be treating someone who is EDS that is also pregnant, that also has hormonal changes, and towards the end of their pregnancy will be becoming more and more lax, on top of being as lax as they already are. There are a whole bunch of other common issues that seem to cluster around EDS, such as POTS, dysautonomia, GI issues, anxiety, so on and so forth. And just being educated about those things means you can provide better care, and you can point to the specialists that they need to see. One of the things that is talked about a lot is how there's a subset of EDS called vascular EDS that impacts blood flow and such. That is something to really pay attention to, because if a person starts having dizziness, heart racing, faintness, then that definitely requires a referral out to get them evaluated to make sure they don't have vascular EDS, because that requires even more tailored and specific exercise programs based on their symptoms. So, this has been the podcast on EDS, the short, down, and dirty. From my experience, it has not been exhaustive, but hopefully it has been informative enough. And if people want a part 2, I am more than willing to do a part 2. But this has kind of been in a gist, my quick summation of what I've seen, what I know. And if you know more than I do, or if you think I made an error, go ahead and drop a comment. But as always, don't forget to like, comment, and subscribe, and share this with everybody that you know, because the American healthcare system is Byzantine. It is confusing, it is labyrinthine, and it is, in a lot of cases, outdated when it comes to how it should be able to share information and get people educated to see the people that they need to see. So hopefully this has helped you become more educated and armed with knowledge to drive a better conversation and discussion with your healthcare professionals, because like I said earlier, this does not replace any medical advice or evaluation, and it is purely meant to educate and inform. So in closing, EDS, hypermobility, is a control problem, not a flexibility gift. Stretching what's already loose is not going to help, but strengthening it will. Strength training isn't just safe for EDS, it is critical, it is necessary, and in my opinion, it is mandatory. Teens would benefit from building healthy habits while they are young. Adults need to know that it's never too late, and a lot of times the progress is never going to be as fast as they want. And the final tip that I give you, anybody who has this condition or thinks that they have this condition, is find a physical therapist who treats you like an athlete with different rules, not as a fragile flower. So, thank you all for tuning in. I hope you all stay fit, stay healthy, and stay awesome. And I will catch you guys all in the next episode.